Hello, in this video I will demonstrate factor analyses in SEMA, and for that we're going to be using cell cycle progression and immune infiltration and their correlation with overall survival and how they are affected by different mutations, copy number alterations, and overall mutational burden in cancers. So first of all, let's put in the factor nodes that are associated with cell cycle. And with immune cell infiltration, we just call this immune. And next we're gonna put in the marker genes for each. So cell cycle, we're gonna put cyclin B1, cyclin E1, PLK1, and MK67, some of the best known markers for cell cycle progression. For immune infiltration, let's put in CD3 receptor components, CD3E, CD3G, CD247, and granzyme A. You can put in more. The results are not going to change. So we're going to change the link type to factor, and now we're going to load our factor nodes with their indicator variables. So cyclin B1 goes to cell cycle, PLK1, MK67, and the rest goes to immune. Now, just to make sure that they're correctly loaded, if they're correctly loaded, you're expecting to see thick lines, and that is what we see here. So let's add overall survival and just very quickly change this to causal. Let's see just very quickly how these two factors affect overall survival. Now, this is showing the average z-score across all cancers here, overlaid on the on the graph. So as you would expect, high immune factor correlates with better survival, and that is indicated with the negative score. And high cell cycle you would expect to correlate with worse survival, and that is indicated with the positive score. So now let's look individually. So this is showing for breast cancer, but then when you look across all cancers, generally higher immune infiltration, the blue line, indicates better survival. Let's look at the z-scores for individual cancers, and then with the exception of GBM and low-grade gliomas, where immune infiltration actually predicts significantly worse survival, and we can get to that later. In many other cancers, immune infiltration is actually associated with better survival, and specifically bladder, breast, cervical, head and neck, liver, and melanomas. So how about cell cycle progression? And this is pretty much across the cancers is associated with worse survival in head and neck, kidney chromophobe, kidney renal cell carcinoma specifically, papillary carcinomas, low-grade gliomas, and so on and so forth. Now let's see how different mutations may affect cell cycle and immune infiltration. So we know that mutations in P53 would affect cell cycle, because P53 is a direct negative regulator of cell cycle. And in fact, let's check if P53 would also affect immune cell filtration. And what you see here is exactly what you expect. So P53 mutations are associated with higher cell cycle progression in pretty much every cancer here. So what you're looking, when you're looking at z-score, what you're looking is 2. So make 2 or negative 2 your point of reference. This roughly corresponds to a p-value of 0.05, and in most cancers the magnitude and the significance of effect goes beyond that, especially in breast cancers. When you look at the raw data in breast, so whenever P53 is mutated, cell cycle factor is significantly higher. How about immune cell filtration? Let's look at z-scores first across all cancers, and it's not as consistent, but mostly with the exception of AML, where immune infiltration is not really a factor, so you should not. Let's just remove that from here. So we're not supposed to look at immune infiltration there. P53 seems to be associated with lower immune cell filtration, specifically in head and neck cancers and in esophageal cancers and in stomach cancers. This might be an interesting phenomenon. Now, we know that immune cell filtration is affected by mutation rate, so let's pull that out from the PanCan iAtlas. Let's just mute, and then here's our silent mutation rate, non-silent mutation rate. We're going to check non-silent mutation rate, and we know from past studies that tumor aneuploidy also is an important factor in immune cell infiltration. We're going to put that in, and we're going to check first of all how p53 affects these, because we would expect p53 to affect these, and then we're going to see in fact, let's check how they also affect cell cycle. Just tidy up the here so that we can clearly see things. Alright, evaluate. So p53 mutations are associated with significantly higher aneuploidy. This is what you expect in pretty much every cancer. And with higher mutation rate, which it's to a lesser extent than aneuploidy, but still there is a significant effect. Now, non-silent mutation rates correlate with higher cell cycle, especially in kidney and in prostate cancer and in stomach. Aneuploidy also correlates highly with cell cycle progression. These are things that you would expect. How about non-silent mutation rates to immune cell filtration? How about that? So, with the exception of testicular cancers and thymoma, again, we're not supposed to look at thymomas because those are defined by T cells. So, generally, there is tendency towards higher, I would say, but not really. The effect is not as strong of non-silent mutation rates to immune cell filtration. Stronger effect is might be seen with aneuploidy scores. So again, with the exception of GBM and low-grade gliomas, where immune cell filtration actually has a positive effect on worse survival. So in many cases, aneuploidy predicts less immune cell filtration, as also reported in the literature recently, and specifically in head and neck, in esophageal, in pancreatic, and in melanomas. We can see specifically in melanomas higher aneuploidy. The aneuploidy scores are not really that clear, but at least if we let's try logging scale X. No, the association is still not clear, but at least statistically it is quite significant, and this is again something that was reported in the literature. So yeah, so this was the analysis of how cell cycle progression and how immune cell filtration affects survival, and they are themselves affected by different tumor parameters across cancers. This was a demonstration of the use of factor analyses in SEMA.